It is now my pleasure to introduce today's speaker, Benjamin Lutzi. Please go ahead.
Thank you, Ryan. My name is Benjamin Lutzi. I am the Senior Advocacy Associate for the American Society for Healthcare Engineering at the American Hospital Association. And it is my distinct pleasure today to kick off our number 2 out of 3 COVID recovery webinars. Today's webinar is titled Short and Long-Term and ITM Needs. Today's webinar is provided as a service to ASHE members, and this recording will be made available to members and the general public for the time being via the ASHE COVID Resources website. The information that is provided by ASHE and the speakers today is a service to its members. This information provided may not apply to a viewer-specific situation and is not a substitute for application of the viewer's own independent judgment or the advice of a competent professional. ASHE does not make any guarantee or warranty as to the accuracy or completeness of any information provided. ASHE and the authors disclaim liability for personal injury, property damage, or other damages of any kind, whether special, indirect, consequential, or compensatory, that may result directly or indirectly from use or reliance on information in this webinar. As a recap, our previous webinar that was held on Friday, May 8th, discussed pre-planning and immediate needs. The webinar, which the slides are attached in the files pod above the chat window, cover introduction and overview, the bigger picture, pre-planning, pre-recovery planning, which includes financing, staffing, facility preparation planning. The presenters also discuss specific facility management issues, regulatory compliance, maintenance strategies, damages, ACSs. Also included in the presentation was immediate needs, so your workload, critical infrastructure, demobilization, and they also discussed the checklists, which are available at ashe.org/COVID-19 recovery, and also included in that same files pod above. So at this time, I would like to introduce our speakers today. Josh Brackett offers numerous perspectives into healthcare facilities management due to his diverse background. Starting his career in fire protection design at a national engineering firm, Josh gained a strong foundation in codes and standards. Later transitioning to a fire protection contracting company, Josh developed regulatory processes and procedures for hospitals. As the on-site special projects manager, Josh leads Joint Commission and Regulatory Compliance, Energy Management, and Process Improvement, and at Arkansas's largest healthcare organization, Baptist Health. Josh also co-founded Legacy FM, a company focused on developing training programs for facilities management teams that empower the men and women that keep our buildings running. Josh is a licensed fire protection engineer, has senior status at ASHE and ACHFM, serves on NFPA's Healthcare Codes and Standards Review Committee, several NFPA committees, and serves on several projects for the NFPA Research Foundation. Welcome, Josh.
Thanks for having me.
Our other presenter today is Frank Rodeluso. Currently, Frank serves as Director of Facilities Organization Readiness, responsible for facilities regulatory compliance, planning and scheduling, dispatching, and facilities operational excellence for New York Presbyterian Hospital. Frank's experience at NYP includes Field Director, Facilities Operation, Manager of Life Safety, and Manager of Fire Safety. Frank earned a bachelor's degree of science and a Master of Engineering degree in fire protection engineering from the University of Maryland. He is a registered fire protection engineer and certified healthcare safety professional. Frank currently serves as the ASHE Regulatory Affairs Committee and is the current task force leader for the ASHE Members Tool Task Force. Welcome, Frank.
Thank you for having me.
At this time, I want to turn the time over to Frank, and he will start with our short-term needs. Go ahead, Frank.
Great, thank you, and welcome everyone. So today for the short-term needs, so this section addresses important issues and concerns related to the de-escalation of the event and ongoing activities. So the goal is to identify needs that may continue to exist and issues that may present themselves as a result of reestablishing normal operations. It is very important to stay current with CMS and CDC and your state recommendations. We have that the CMS Phase 1 restart of non-COVID-19 care spaces as clinically appropriate and consistent with public health information and state authorities. You should look at maximizing the use of all telehealth modalities, sufficient resources in order to provide care across all phases of care, adequate facilities for ongoing testing and post-acute care for patients. Also should look at adequate facilities for operations and storage of supplies, and provisions for use and storage of PPE. Impact monitoring, so we're looking at staffing needs. So a lot of work is done in the previous phases of the COVID-19. Some facilities may have furloughed staff. We have to look at the staffing that's going to be required for moving forward, whether bringing staff back or if we reallocated resources of staff to other areas. An assessment of these and other issues will be required to plan for expected and unexpected concerns during the short-term operations. Space utilization, spaces that we changed and converted, will we convert those back to what they were? Looking at surge areas for a second surge. What additional utility needs you will need, if we had additional oxygen and power, electrical requirements, what will be needed in the short term moving into the long-term phase. For contracted services, any workers should schedule their work such that they will be accessing either only COVID areas or non-COVID areas on a given day, and they should also be trained in the importance of not moving from one location to the other. So you don't want them going from a COVID unit to a non-COVID unit. Some general considerations, so prioritize care. Working with the clinical teams, looking at surgical care and procedural care. We mentioned consider non-COVID areas or zones, dedicating certain zones to non-COVID care. We'll talk later about alcohol-based hand rubs and the storage of those. Sufficient resources should be available without jeopardizing the surge capacity. We want to be looking at the supplies needed and testing, what types of facilities we have, the workforce, as I mentioned, make sure that they're healthy and coming to work. As non-COVID care begins to be offered, we're going to be looking at social distancing practices, separate non-COVID areas from COVID areas, separate entrances, whether it's staff entrance only, patient entrance only. CMS recommends that during phase 1 for administrative and engineering controls that we establish social distancing, such as minimizing time in waiting areas, spacing chairs at least 6 feet apart, and maintaining low patient volumes. As non-COVID care begins in your facility, it's also recommended considering the availability of alcohol-based hand rubs, masks, gloves, and different PPE, in addition to evaluate the social distancing practices. Prepare non-COVID-19 care triage areas in order to screen non-emergent care patients as they enter the facility, and establish social distancing parameters within the facility, which we'll cover in another slide about the 6 feet and waiting rooms and getting in line. Facility and space utilization, so this may need to be dynamic. Patient care spaces require careful consideration to ensure patient and staff safety. It is important to examine changing facilities needs with the assistance of qualified facilities professionals that can assess the facility's engineering controls and patient flow and help verify that response efforts will properly protect patients, staff, and visitors. It is strongly recommended to use a multidisciplinary approach with professionals, including, but not limited to those listed, from facilities, infection control, environmental services, risk manager, and clinical staff. Make sure you're all discussing what the plan is to move forward and not working in silos. For facilities and space utilization, so a lot of changes were made to address and deal with the COVID situation. Ventilation requirement verification will be needed. Any spaces that you converted back should, at a minimum, go to the original design. If you affected or impacted an entire system, you may consider looking at moving to the latest applicable standards from ASHE 170. Make sure the pressure relationships match what the room is going to be used for. Inspect your filters and change as needed, discussing that with infection control. And follow CDC guidelines for air exchange contaminant removal, which I'll cover on the next slide. And of course, perform terminal cleaning, so working with your EVS staff to make sure that the space is terminally clean. Again, if screening and testing is not performed, we want to look that patients be considered to suspect COVID-19 and to follow the CDC guidelines for air exchange contaminant removal. So the CDC put out the recommended practice table B1 shown here, based on the air exchanges of your room on the left side. So for example, if you had 8 air exchanges to remove 99% efficiency, you would be looking at 35 minutes. And if you were looking for 99.9% efficiency at 8 air exchanges, you were looking at 52 minutes that you would have to wait until you entered the room or space. So some other considerations: social distancing spacing. Markings should be provided to indicate patient spacing as shown by the red lines in the image. Spacing should be considered in all directions shown by yellow circles. Social distancing spacing should also be indicated where patients interact with staff, limit staff exposure as well. So we should be looking at our waiting rooms, how we will be designing waiting rooms and areas where there are patients that are coming in. Some other considerations that we should be looking at: budgets. It's important to be tracking the costs as we move into the next phases. Yes.
Frank, if I can interrupt you for a second, your audio is struggling a little bit. Could you get slightly closer to the source? The audio is becoming kind of shaky and unclear.
Okay. How's this?
That sounds better. Thank you, Frank.
Great. So other considerations are budgets, infrastructure impacts, what are, as we move from the short term into the long term, Josh is going to discuss, we should be looking at the infrastructure impacts, the changes that may need to be made as we're looking at surge, a second surge, storage of additional supplies. We should be mindful of supplies such as alcohol-based hand rubs. We need to meet those requirements at all times, and contracted services. Workers performing these services should have knowledge of unique intricacies of working in the hospital. They should be routinely screened for symptoms of COVID-19. And workers that access critical areas should be trained on how to properly assess that zone for COVID with PPE and proper decontamination procedures. Decisions should be consistent with public health information and in collaboration with state public health authorities. And careful planning is required to resume in-person care of patients requiring non-COVID care. Now I'll turn it over to Josh to cover the long-term needs.
All right. Thank you, Frank. Appreciate it. Thanks, everybody, for being on as well. For the long-term needs, I was asked to speak on the long-term needs because I think a lot about the long-term impact, the code impacts. So ASHE's come up with some really good documents associated with the long-term needs. And some of those are, hopefully all of your hospital systems are keeping track of all the temporary changes that have been made to the facilities that you manage. And if you haven't, then highly advise that you do that. Get with your team, go back and try to reconcile all the temporary changes as well as the permanent changes that you guys have made. So we know that there's going to be changes to the hospital that aren't going to revert back. We've seen permanent changes to air handling units, to buildings to get additional outside air to make facilities more negative. So make sure that you're documenting all of those changes for when your accrediting organization comes around for you to be able to present that documentation. One of the most important things that we have the opportunity right now to do is to collect data for future analysis of code development. This is a big platform that ASHE stands on that I've stood on for quite a while. But we have the opportunity to use data to help develop codes in a way that helps our facilities in the future. So ASHE is going to have the ability to upload data and resources and information. So as you guys think of things, please reach out to ASHE. Please share that information. You're going to see a lot of emails come across for sharing data on specific topics. We'll talk a little bit more about those as well. But that's going to be huge to the code development process in the future. Also, development of case studies. We know like there are hospitals in New York, like Frank's Hospital, for example, that had surge, had a lot of patients, and then there were hospitals that didn't, right? And we're actually going to want to see case studies on both of those. How did this impact not only large metropolitan areas, but how did it impact the rural hospitals as well? From all aspects, from sourcing of supplies. I know Frank actually took a lot of the supplies that were meant for our hospital because they needed it more, right? So, but how did that ultimately end up impacting smaller rural facilities as well? Overflow of patients, and then respite for staffing as well. Those are all important topics. So please keep an eye out for your ability to help facilities management grow into the future. After action reports. So this is not going to be a typical after action report for a standard emergency response activity. This one is. We've had many discussions about this, and this is, all I'm going to say is good luck. It's not going to be easy to document everything, but it is critical for us to be able to, because if we do have a surge or in the future, if we have a different pandemic, we have a lot of lessons learned that we can take and share for the future. So it's very important that you develop a comprehensive after actions report and include it in your annual emergency management review. Corrective actions also need to be documented and completed, as discussed. Your accrediting organization will be looking for those temporary changes that converted back, when they converted back, why you converted them back. So just make sure you have all of your decisions there. Flexibility. So establishing flexibility for hospitals. I think we've all learned that we need the flexibility to more easily convert units, rooms, suites, floors, entire hospitals in some cases to negative pressure. So learning, developing the codes and standards associated with that, developing those best practices, how to get negative pressure more easily, how to use your AHU's economizer cycles if available, understanding not all rooms need to be negative pressure, but you need the ability and flexibility to convert them in the event that you need to. And again, it goes back to what Frank was saying about the non-COVID care areas. COVID care areas, look at your ability to flex and steal off certain areas of the hospital without impacting the entire population. One thing that I think would come out of this as a positive is we have the ability, we've deferred a lot of maintenance, a lot of ITM, we furloughed a lot of facility staff, for example, that were handling a lot of these. So we've had to make some hard decisions, but I think that will help us gear up to do a more reliability-centered maintenance program. So learning what is critical for maintenance, what isn't critical, how can we, instead of basing something off of a time frame, replacing HVAC belts at a certain time frame, can we look at vibration analysis and other metrics to help us make smarter maintenance decisions. So that's gonna give us more flexibility associated with the demands of our maintenance staff, and it's going to help us advocate for risk-based assessments for ITM frequencies. A big one there, of course, is like fire alarm, for example, or sprinkler. If we have the ability, if you guys are willing to share that data with ASHE, then we can take that data, depending on how it proves, and take it to the codes and standards and further develop that. Maybe we don't need to be testing tamper sits just semi-annually. Maybe we don't need to be testing supervisory signals quarterly. We don't know because we don't have the data, but this will help us develop those risk-based assessments to take that to the codes and standards committees and roll that out. So again, just make sure you're keeping track of that data and adjusting your maintenance strategies accordingly. Staffing. So this is just Josh's personal opinion. I hope it's not the case, but we've got to be keeping track of our staffing, the details. What are we not doing? What are we deferring? I have a fear that not everybody is going to be coming back to facilities or just the hospital in general. So keeping track of what you need to justify your staffing needs. What have you not done as a result of COVID? What have you deferred? What impact is that going to make on your equipment by deferring that maintenance? So this will help ensure that you can make changes quickly, you can respond quickly. If you've already got the data and you're already tracking your staffing needs, then when you are asked, do you really need this many staff for a certain facility, then you have the data associated with that and say, here's the things that we've deferred, here's the things we didn't do, here's the code impacts, here's the maintenance impacts. So that's very important. Energy impacts as well. I know this is probably far from a lot of people's minds right now, but those facilities that are focused on energy efficiency and are operating more energy efficient than others, clearly by us increasing negative air, increasing fan energy, we've decreased our energy efficiency. So understanding and documenting that, clearly operating in the pandemic is more important than the energy impacts, but understanding that there are potentially utility cost increases associated with it, and just having that open dialogue and communication with your executive leadership is important. Training for staff for pandemic responses. There's been a lot of training discussions associated with facilities teams, understanding how they need to respond in certain situations, addressing their fears associated with going on COVID floors or suites or areas or rooms to do work. How are we keeping them protected? How do we address other emergencies that may happen during a pandemic response? I mean, our facilities are located in Tornado Alley, and right now is tornado season. So understanding that impact as well. So make sure that you are still thinking about training for pandemic responses and other potential emergencies and how to address maintenance concerns as well. Best practices. So there are several best practices that I think are resulting from numerous different parties that ASHE's been reaching out to, having conversations with. And these are just a few of them. We'd love to see in the chat you guys have any other best practices that we can add to these. This is just some of them that have been developed. But understanding bulk oxygen and calculations, just med gas in general, preventing it from freezing up. I know that's a big deal whenever when you're developing med gas systems. So I think that brought to light a lot of understanding of most facilities weren't prepared to have hundreds of events running at one time. Right. So understanding the impact associated with that, I know Frank can speak to that specifically. Understanding how to create functional ORs with negative pressure anterooms. How do you get patients into the OR? The actual process associated with rolling a patient into the OR, creating an anteroom, having a HEPA filtration that is, and where's it discharging at, right? So getting a gurney into an OR with double doors is no problem, but once you add a three-foot anteroom onto it, you may not be able to make that turn. So you may have to make a temporary solution where the walls go up after the patients are in there. Who's putting those walls up? So making sure you have those kind of plans developed. There's a lot that goes into that. There's a lot of concern with doctors and nurses associated with intubating COVID patients and wanting to make ORs negative, right? So this solves both scenarios and puts the doctors more at ease, as well as gives you the negative pressure that you're not pushing it out to clean areas. Understanding patient area, HVAC systems, and flexibility, we've discussed that. But definitely knowing what your HVAC zones are, how can you wall those off, how can you reverse the pressure associated with it, make them negative. Understanding egress calculations. So one thing that has resulted from this, especially with the units that have gone, entire units or floors that have gone negative, are how do you egress the building? So code does say, and I'm probably going to get this wrong, I think it's 5 pounds initiating force, 15 pounds initiating force, 5 pounds continuous for egress. So just again, understanding what those impacts are. Are you still able to meet those calculation criteria? And if not, have you done a risk assessment to address that? I think we're definitely going to be seeing a revision in how HVAs are created. I don't do a ton of work with HVAs. I do get to hear a lot about them in the meetings, but I think the development process, if anybody actually had a pandemic on their HVA, I think you guys were probably very well prepared for this. But I think most facilities will definitely say they didn't have this on an HVA, or if they did, it was so far down the list there wasn't an actual response ever performed. So so we talked about this a little bit, what maintenance is essential and what can be foregone. Again, so this goes back to the reliability-centered maintenance strategies. How can we leverage that? How can we decrease maintenance? If we do have to live long-term with less staff, how do we make that work for us? So, and we do have a great question. So HVAs, hazard vulnerability assessments. So I apologize on that, but so hazard vulnerability assessments, what hazards are your facility most likely to encounter? Tornadoes, large-scale wrecks, pandemics, things like that. So it's an emergency response related. ITM and maintenance. So several of you have probably seen the ASHE ITM checklist that has come out. ASHE Joint Commission both submitted to CMS for extension for ITM activities. It has been approved by CMS, but that ITM waiver has been approved. It's a blanket waiver, but it must have local and state AHJ approval. So before you go and just stop doing your ITM activities, please make sure that you've got it covered. So there are certain physical environmental requirements. This permits facilities to schedule the ITM frequency activity. We're going to go through a table here in a little bit, and it goes through what's required by Life Safety Code. So there are a few things that were submitted to CMS that were not accepted as part of the blanket waiver. The monthly electric and weekly diesel fire pump test, so you have to continue doing that. Monthly fire extinguisher inspections must be continued. Monthly elevator firefighter recall tests, monthly generator and ATS tests, and construction daily means of egress inspections. So, and I think we are actually just going to take a second. We're going to go back and to the previous slides. We're going to let Frank go through. We had several people say that they weren't able to hear the last 3 slides Frank went through. So before we continue the ITM, let's make sure we cover Frank's last 3.
I got it, Josh.
Okay.
Okay, great. Okay, so we apologize for some issues with the call. So the table B1, so CDC had recommended the air exchange and time required for airborne contaminant removal by efficiency. So in the slide here, if you have on the left 8 air exchanges and you're looking for a removal of 99% efficiency, you would be looking at 35 minutes before you should enter that space. If you're looking at 99.9%, it would be 52 minutes. So you would use this chart to find the air exchanges for your space and then the time required for the removal. So social distancing spacing, so we should be looking at our waiting rooms and areas where we typically have lots of patients gathering together. Marking should be provided to indicate patient spacing, as shown by the red lines in the image. Spacing should be considered in all directions, which is shown by the yellow circles. And social distancing spacing should also be indicated where patients interact with staff to limit exposure as well. And these diagrams will show you examples of what a waiting room did look like, and now with social distancing, some of the chairs that you would need to take away, and the spacing that you would be required to have to practice the social distancing. Other considerations are budget considerations, infrastructure impacts and requirements. We should be looking at the infrastructure changes that were made during previous requirements and needs and what the future looks like, what spaces you're going to keep, the budget constraints of keeping that infrastructure in place, the availability of hygiene products such as alcohol-based hand rubs and masks and gloves, remembering that you are still required to follow all storage requirements for alcohol-based hand rubs. Contracted services, workers performing these services should have knowledge of the unique intricacies of working in a hospital. Workers should also be trained on the importance of not moving from non-COVID care areas versus COVID care areas. And these decisions should be consistent with public health information and in collaboration with state public health authorities. Careful planning is required to resume in-person care of patients requiring non-COVID care. That's it. And Josh will move into inspection, testing, and maintenance.
Awesome. Great. So we'll continue on. So it is important. Frank just mentioned the alcohol-based hand rub dispenser. So this was waived. There was a waiver that was put out, I believe it was yesterday, by CMS to waive the prescriptive requirements for placement of these, and that means basically within 1 inch of a ignition source, so a outlet, for example. So this is something that I'd caution everybody just to really think about doing. Is it really necessary to do it? So just think about that before you place a ABHR directly above an outlet. So restrictions on storage requirements were not waived, as Frank mentioned as well. Frank and I both have had several discussions about this, where just as fire protection engineers, we've seen pictures of rooms full of alcohol-based containers, as well as I've seen a few pictures with just full-grain alcohol from distilleries. So, just really think about your placement and locations. Work with your central supply. Make sure they're storing things appropriately in the right places. The last thing we would want is to create a room that's essentially a bomb. So make sure you're making smart decisions on where the additional sanitizer is being stored. Fire drills have been waived as well. But you do have to provide documentation, orientation of a training program where you have worked with staff and you've trained them on the fire drill. So make sure you review that waiver as well. And temporary construction requirements, this would allow temporary barriers between, if you've got semi-private patient rooms, for example, you could put temporary barriers between them. Again, I want to caution everybody, think about the actual impact associated with that. You may have a sprinkler head that can no longer reach a wall if you just put up a wall. So there are things to think about. Just because it's waived does not necessarily mean it's the right decision for your facility. So talk through it. Make sure you have that diverse group, as well as Frank mentioned, to think about the pros and cons associated with it. ITM deferral, you do need to document. ASHE has created a very helpful table associated with this, and it's specific to each item, each EP, and you have to have justification for your adjustments. And we're actually going to get into that now. So I think it'd be good at this point also to talk about, not all facilities are doing this. I think Frank and I could talk a little bit about what our facilities are doing. Our facility actually did a risk assessment before this was ever adopted, and the only thing that we personally opted to defer was air handling unit shutdown associated with fire alarm ITM, damper shutdown. So anything associated with air movement that would potentially reverse a negative pressure room and negative pressure COVID room, suite, floor. Frank, do you want to talk about what your facilities opted to do?
Like you said, Josh, and in speaking to different organizations, I think it depended on the area and the impact. As you know, some services are contracted out. So we've had facilities where the contracted service, the vendor, could no longer come to the site to provide those activities. I think you touched on the most important part, is that a risk assessment should be done and documented. If you want to utilize the information from the 1135 waiver, but you should really have all the supplemental documentation, as there are multiple AHJs. So like here, we have the Fire Department of New York, still have to follow all the NFPA 25 requirements. So we really need a risk assessment with proper documentation and backup to justify how the COVID response impacted us from, doing any of the inspection, testing, and maintenance. I think once you go through the documentation here, it will be very helpful so that the sites are well prepared when we go back to surveying to clearly present to the surveyor, what timeframes were missed or deferred, the reason, and have a risk assessment to back it up.
Perfect. Thank you, Frank. So as you can see, what we've got here is just a sample ITM deferral documentation. This table is available. This is just a part of it, but this table is available on ASHE's COVID website. So I think it's the COVID resources website. But this is just a sample that was created so we can just talk through a few examples. So you have your specific ITM requirements, what it is, from So this one is the fire protection suppressant. So this is actually, if you're familiar with Joint Commission, this is EC 235, and this is EP1 supervisory signals. Right. So what specifically waiver are you adopting, yes or no? If you check it, it's yes. If you don't, it's no. So for this example, control valves, the waiver was adopted. The date they were last completed was January 15th. The waiver allows for a 60-day extension, and we're just making an end date here. This is not an official end date for the waiver. So, but you'll know when the waiver. Just keep an eye out on ASHE's website, on CMS's website for when the waiver actually does end. So assuming a June 28th waiver end date, the testing would then be due 60 days after that, so putting it at 8/27. You have to have a reason for the deferral. As Frank mentioned, here's an example, service vendors were not allowed within the facility, and this is a drop-down menu as well. And then your observations, comments, actions, what are you doing? So that test was scheduled for August 19th, for example. So also a point of caution on this, if you're in an area where you have limited ITM service vendors you've got to consider the hospitals around you that are taking waivers too associated with that. If everybody takes the 60-day waiver, then everybody's now put into the same bucket. So it may not be best for you to wait until August 19th. So be considering that as well. Don't wait until the last minute. The quicker you can get it scheduled, the quicker you allow vendors back into your facilities, then the easier it may be for you to get that service. Water flow devices, very similar. So these are semi-annual testing. Supervisory signals, I should have mentioned, I apologize, are quarterly testing, required quarterly. Water flow is semi-annual, same thing, tested on January 15th, 60-day extension, waiver end date 6/28, so due August 27th. Initiating devices, notice that they did not take the waiver on this sample because they were tested on January 15th. They're not due again until January 15th, the next year, 2021. I apologize. I thought I was using the arrow. I've been moving my cursor around, not the arrow. So, notification devices, same thing. They're not opting to take it because they were performed 9/29, so they're not due again. This is an annual requirement, not due again until 9/29 the next year. Fire pump, electric motor drive, no flow conditions, so this is a monthly requirement. Notice this was not waived by CMS, so facilities still have to continue doing this. So that will continue just as noted the next month. Fire pump under flow conditions, this one was waived. The waiver was adopted. So March 15th was when the last date was completed of 2019. Notice the date 2019. There is a 60-day extension that they're opting to take. Waiver end date again June 28th. So they must have the annual fire pump flow test completed by August 27th. So this is all on ASHE's website. We just wanted to walk through a few examples. And please feel free to ask any questions in the chat. We can talk about them. Frank, you have anything to add to this?
No, I think you covered it all. Again, the great resource is the checklist. Give everyone just a reminder and good indication of what falls under each of the categories, and just to follow that.
And the checklist is also available in the download section of the files. I'm sorry, the download in the files section of this presentation. Thank you, Jonathan, for pointing that out. The ITM, again, it's broken up into different categories, so make sure you go through that checklist. It's got fire protection and suppression, utility systems, emergency power systems, med gas vacuum, medical equipment, and life safety. Okay, and we've got a little bit of time left for questions. Frank, anything else you want to cover before we turn over to questions?
Nope, I'm good.
All right. Benjamin, have you seen any questions come across that we need to address?
Yeah, there are a few. Jonathan has made me aware of a couple. So the first question that we had come through that we wanted to get addressed is, what if stacking and planning departments with similar HVAC requirements adjacent to each other to increase efficiency in operation? So rethinking architectural planning. This was, we're assuming, in regards to the short-term facilities planning information. Frank or Josh, do you think that there's any, potentially differences in rethinking how architecturally hospitals will be constructed after the pandemic?
Yeah, I mean, Frank, you want to start or you want me to?
No, go ahead.
Great. So, yeah, I think there are. I think hospitals will be looking at more flexibility for being able to make entire wings or floors negative. I think there's going to be an increase in AII rooms in general. I think that, flexibility associated with the HVAC system is going to change, and again, I think that's going to have to be a conversation with multiple groups and departments, because again, that's going to impact the potential of your energy conservation efforts as well. So it's going to have to end up coming down to a discussion in the short term, at least, with facilities. In the long term, we'll see how code plays out. One of the big things I think we need to think about is making data-based decisions for our code changes. Unfortunately, codes tend to react rather volatilely towards major scale events and not necessarily have all the data in place before those decisions are made. I hope that's not the case here, and I think we've got enough participants on the phone and on the call today where if we can share that data and we can get that data, then we can make informed decisions about the direction the codes need to take.
Yeah, great, Josh. I think we should have learned from the lessons learned through what we've experienced already with the infrastructure and utilize that to make decisions on future projects.
Thanks, Josh. Thanks, Frank. One of the other questions that we got is, should we put changed air filters into a red bag? And before both of you respond, one of the things that we wanted to make sure is that people are aware, ASHE does have a frequently asked questions section for filtration on the ASHE COVID-19 frequently asked page, or frequently asked question page. So this question is addressed there. There are some other things with filtration, but Josh, Frank, do you want to kind of let everyone know how you're handling things like that?
I'll tell you specifically what our facility is doing. We are not changing filters. We've had several discussions about it. From all the data that we've seen, by the time it reaches the filter, there's the virus isn't living anymore. So again, this is going to come down to your specific facility, the epidemiologist that you have on staff, what your facility is particularly comfortable with. That specifically, though, is again, I think that it's important to definitely have those discussions. Frank?
Yeah, I agree. That with our multidisciplinary team, with infection prevention control, you should establish that protocol for your site specific.
Thanks, Ray. Thanks, Josh. Jonathan, did you notice any other questions you wanted to get addressed?
I actually see one just looking through right now. So somebody mentioned, is there a current matrix for staffing? ASHE does have a, and I can't remember the name of it, Benjamin and Jonathan, but there is a staffing spreadsheet essentially where you can input all the data for your facility and it will recommend a benchmark. There is a staffing benchmark, and it is very, very useful. It does take time to complete it. I highly, highly recommend doing it though, because it has helped numerous facilities that I know firsthand retain staffing that was asked to be cut. So I think that's a very, very important thing to be thinking about.
And thanks, Josh, for addressing that one. That was one I was going to bring up. This is Jonathan Flannery, the Senior Associate Director for Advocacy at ASHE. That spreadsheet Josh mentioned is available. If you'll search on our website under benchmarking, you'll be able to find that. And then if you have questions, call Josh, please, not me. I'm just kidding. It is a pretty complicated document, so reach out if you need help on that. We'll gladly help out on that. That was the only other. There was the only other thing I'd point out is there was a very lively discussion on the seating and what to do with the chairs. I think it was very well addressed in the chat. If you, like most facilities, don't have storage for those, so taping them off. Again, it's very important you get with that multidisciplinary group, discuss that as a whole group, and make sure that you have a consensus on that. But taping them off, making sure that they're turned to the wall if you can, something of that nature is very helpful. There was also a comment in here about vertical distancing. I personally had not really considered that. So if you have an assembly type setting where the seats are tiered, you really need to take that into consideration also, and that's a very good point. I had not considered that, but you should really consider that when you're looking at that. The 6-foot social distancing is a very important part of all that we're doing. So, and then the last thing we had was someone requested to know if there are CEUs for this presentation. I know we've applied for them. We'll have to follow up with that. Anyone who has logged in will get those processed out if we can get that worked out for you.
I do see one more question I'd like to address, John. So there's a question on our facilities looking at touch-free or antimicrobial fixtures. Absolutely. I think I've heard a lot of discussion and rumbling about that. A few things to think about on there are battery-operated versus power. Clearly, battery-operated is easier for retrofit immediately, but there are maintenance impacts associated with that. So I think that is something very important. That's the right mentality to be having. Let me say that is thinking about ways to do that. A lot of facilities I've seen are also retrofitting the touchless restroom doors, for example, having a little kicker down at the bottom to use your foot to open it instead of having to use your hand. So great way to be thinking about it.
The one thing that I would like to add on the touchless faucets, there's a really good study out there, and I don't remember who, I think it was the University of Purdue produced it, in regards to an increase seen in Legionella issues with touchless faucets in clinical settings. So there's a concern about that. Be aware of that. I would Google touchless faucets with Legionella, and I'm sure you'll be able to find that study. So
very great point.
It's because of the way that mechanism is set up for the touchless faucet, it tends to keep water in it and that's where your biofilm grows, and it can cause a waterborne pathogen issue there. So be aware of that.
Great point.
We just had one come in regards to requiring staff to wear masks in administrative areas. Josh and Frank, what's your facility doing there?
Frank, you want to do that? Take that one first?
Yeah, so all of our staff are wearing masks. If you're in an office space by yourself, you could take it off, but otherwise we are all wearing the mask in any spaces that we are being within.
Absolutely, same here. So that's exactly what we're doing. The only time that you're allowed to take it off is if you have a personal office. Then you can take it off in there.
Well, if there's no further comments or questions from the presenters today, we just
there's a
had
great
one more question come in about HIPAA.
So, boy, this is a really good question. Thank you, Benji, for this. HIPAA violations when patients stand 6 feet from registration. We've got to come up with ways to protect the staff. If you're worried about that HIPAA violation because of the distance, then you're going to have to provide some type of barrier so that the patient can get closer, but yet not expose your staff or the patient from your staff. So there are alternate ways to do that. A plastic plexiglass barrier could provide that. But yeah, be aware. Very good point, though, Benji, that we need to keep HIPAA violations in regards to making that social distancing work. Very good point.
We've actually also increased. Our registration is independent pods, so we've increased airflow to those areas to help with air exchange rates.
Oh, there's the other. I apologize, Connie, for missing your earlier question in regards to textile requirements for furniture in public areas. Again, the codes require certain requirements on that. They do need to be cleanable. So those kind of requirements are already in place. All fabrics have to be able to be cleaned. And again, you don't have to use bleach to clean them. There are many different chemicals available on the EPA N. That's the N as in Nancy list. The EPA N list has a myriad of chemicals that you can use to clean in regards to COVID-19. And we've probably got time for one more question. Paul's question, has anyone added additional local filtration and or UV in waiting rooms? Josh or Frank, have either of you done that?
I can speak to what we've done. So we have had discussions about doing HEPA scrubbers in our waiting rooms. We have bought a few additional UV lights, primarily for disinfecting of patient rooms. We have not had the discussion of doing UV lights in public areas that at least that I've been a part of. So.
Yeah, neither have we.
All right, and that takes us to the top of the hour. We appreciate everyone's questions. And Ryan, we'll turn it back to you.
Thank you, ladies and gentlemen.